Hi everyone, my name's Flint Wang. I'm one of the internal medicine attendings at HUP. Today I'm going to be talking to you guys about Oral Case Presentations 2.0. So you guys have already had a chance to see the 1.0 version of this talk in December when you were about to start clerkship year. Now that you're in clerkship year, we're going to go over advanced presentations, and that's going to mostly center around a review of the regular H&P presentations, but also an introduction into MICU and outside hospital transfer presentations too. For objectives, we're going to go over new floor patient presentation tips. We'll go over expectations for what to do when a patient comes to you on the floor, having been in the ICU or an outside hospital, and we'll also go over day 2 presentations. We'll go over a couple of case presentation examples where you're actually going to get a chance to hear an attending give a presentation and critique them, and then we'll discuss tips to improve complex oral presentations. And I'm going to try to include as many cute cartoons as possible just to keep you occupied. All right, couple disclaimers at first. These are meant to be a general approach. So these are specifically in relation to internal medicine presentations on the hospitalist service. You will find that some attendings will have different preferences. Some attendings will want you to really flesh out the social history, for example, on the ID service where we take care of mostly HIV patients. And then you are going to see big changes. You know, if you go into surgery, pediatrics, OB-GYN, any of the other specialties, you'll have a slightly different style. But most people would consider internal medicine to be sort of the most complete and the most formal presentations. All right, so let's go over a quick review of Oral Case Presentations 101. And these are really going to be your person coming from the emergency room and getting admitted up to the inpatient floor. All right, so in starting with the HPI opening statement. So what is this? You're going to give the name, the age, the gender, the relevant medical history, the chief complaint, and the duration. So remember that for the relevant medical history, you're not trying to give an exhaustive list of all the things they've had done before, just the things that are actually going to pertain to you proving or disproving your hypothesis of the diagnosis of why they're coming in. The duration can be chronic, subacute, acute, or acute on chronic, for example. So one example here is Ms. Williamson is a 72-year-old woman with a history of tobacco use, hypertension, and prior DVT, previously on warfarin, who presents with 3 days of acute onset worsening dyspnea on exertion. All right, now going into the body. Remember, there are 2 different options of how you can present the information in the body. One is by the chronologic order, and the second one is one symptom at a time. Now, I will say that for most patients who are coming through the emergency room and have a relatively straightforward presentation, you're probably going to want to choose option number 1, where you go in chronologic order. So, for example, you can say the patient was in her usual state of health until 7 days ago when, then 5 days ago, then on the day of admission, this worsened and brought them to the emergency room. The other option is to go with option number 2, one symptom at a time. And so this may be someone who's really had a lot of in-depth workup about each symptom, and you want to just go over that symptom individually. So for example, her cough became productive 3 days ago and then nonstop, and you can really flesh out the cough. Then you can talk about the diarrhea. Then you can talk about the muscle weakness, and it doesn't necessarily follow a strictly chronologic order. For brief review of systems, remember, this is the first part where the written documentation changes from the oral presentation. So what you do want to do is to list the review systems symptoms grouped by differential diagnosis within the HPI. So please, please do not give a head-to-toe review of systems in your oral presentation. In the written presentation, in the written note, you will include a head-to-toe, but definitely do not give a head-to-toe review of systems in the oral presentation. You want anything that's actually relevant to be embedded within your HPI, and I should be able to figure out that, for example, your differential includes PE, viral URI, COPD, and CHF. So at the end of discussing what symptoms brought the patient to the ED, you can say that she denies any recent unilateral leg swelling, long distance travel, or pleuritic chest pain. She's had no rhinorrhea or sore throat, non-smoker, never had any wheezing, no P&D orthopnea, dietary change, or missed diuretic doses. So right there, I already know what your differential diagnosis is. And again, try not to go head to toe. Once you do that, your attending is going to know that you're not quite familiar with how to do oral presentations on the internal medicine service. For the ED course, this is a very protocolized way of reporting the ED course. You start with, in the ED, patient's temperature was this, heart rate was this. Then you go over any major lab radiology or physical exam findings. Remember, this is not your full review of all the results. You're just going through things that led to a fork in the road decision. You'll mention any initial therapy started. So for example, in the ED, vitals were notable for temperature, heart rate, blood pressure, respiration rate, saying 83% on room air. Chest x-ray showed a left lower lobe infiltrate. She was started on BiPAP and given ceftriaxone and azithromycin ×1. So I'm going to put a reminder here of the order of the HPI. And the reason for this is when you guys were going through your didactics previously and submitted sample notes, there was quite a range of structures that people took with their HPI. So I want to remind you guys, you have the introduction one-liner. You talk about the progression of symptoms leading up to the day of admission. Talk about pertinent positives or negatives that rule in or out other diagnoses. And that's really kind of your brief review of systems there. Then you go over any relevant past medical history that you want to include within the HPI. So for example, if someone's coming in with an asthma exacerbation, this is where you're going to say, how many times have they been intubated? How often do they use their inhalers, for example? Then you go over the ED course, and especially because most of you guys are going to be admitting a patient, on a Monday and then working on it all day and then presenting the patient on Tuesday, you may want to give the overnight course at that point. In terms of other medical history, you're honestly going to breeze through a lot of this because most of this people assume if it's that important, you've already included in your HPI. So past medical and surgical history, you don't need to list everything. You can just say things that you haven't already talked about that are directly relevant. Now remember, you want to have all of these in your written documentation, but you don't need to tell me about their knee surgery unless you think that it's actually relevant today. Medications and allergies, most real patients who aren't standardized patients have over 20 medications. So it's definitely easier if you organize them by organ system. For example, saying that for CHF, the patient's on lisinopril, metoprolol, isosorbide, and hydralazine altogether. You usually don't have to give dosages unless you're modifying the dose. Things that I do want to hear dosages on are things like opiate pain medications and maybe furosemide or Lasix dosing. Allergies, you can give the reaction if you have access to that. Family and social history, everyone gets a mention of tobacco, alcohol, and drugs. You talk about the job, their living situation, and then if you want to delve more into the social history, that sort of depends on why the patient's coming into the hospital and what service you're on. For example, on the ID service where they take care of HIV patients, you may want to include a sexual history if you think it's relevant. Or if you're taking care of a TB patient, you want to maybe go over some of their exposure risks. All right, next we're going to go over the vital signs. So it's pretty well formatted as temperature, heart rate, blood pressure, respiration rate, and O2 sat on what modality. Remember that if you're going to give all of these numbers and you want to give your maximum and where they are at now, it's a lot of numbers to give all at once. So if you can, if it's a relatively normal number, try to give these in multiples of 10s. For example, Tmax is 98.3, currently 98.1. Heart rate ranged in the 60s to 100s, currently 60. Blood pressure ranged from 90s to 110s over 50s to 80s, currently 105 over 85, and saying 97% on room air. For physical exam, try not to read verbatim. If I hear students trying to say no thyromegaly or atraumatic normocephaly, you already know that this person is going to read you every single part of the physical exam. And honestly, you just don't have time for that on oral presentations on rounds, where presentations for a new patient really need to be about 7 minutes max. So most people will get no acute distress, ANO ×3, your opinion on the heart sound. So for example, regular rate and rhythm, no murmurs, lungs cleared auscultation, abdomen soft, non-distended, non-tender, 1+ edema in the right leg, and then any specific diagnosis related findings. So for example, if you have a cirrhosis patient, you may want to talk about asterixis. And again, if you start to list every part of the EPIC note template, you've already lost the listener at that point. For labs, please do not list all of the labs. Again, document all of the labs, but do not list all of them. You're just going to recite the relevant ones. So for example, when you're reading a basic metabolic panel, please don't read the chloride unless it's actually relevant. And only mention a trend if it's actually clinically significant. So there have been times where I've heard a student say that the INR went up from 1.1 to 1.2, and that's in a patient who's not on anticoagulation, not malnourished. So that 1.1 to 1.2 doesn't really mean anything. And when you say it went up from 1.1 to 1.2, that is going to trigger the listener to say, I'm not sure that this person really understands what an INR is and what is a clinically significant value. For radiology, you want to start in the order that you think the person in the ED or the previous provider would have ordered these. So we usually start with least expensive and least invasive to most expensive and most sophisticated. So for example, most people are going to get a chest x-ray first, then they're going to do a CT of the chest. You want to give the x-ray, then the CT, and then if relevant, an MRI. For cardiology, most people will get an EKG when they come into the hospital. And then you also want to give any echo results if those exist, even if they're in a previous hospitalization. And depending on the situation, you could include left and right heart catheterization results. It really just depends on why the patient's in the hospital. So for normal echoes, the reads are often about 2 paragraphs long. They're very long. So you want to say for someone who has a relatively normal echo, the EF was 65%. They had grade 1 diastolic dysfunction. There's some mild tricuspid regurgitation and moderate aortic regurgitation. And then the PASP was 30. So if you're not familiar with that, the PASP is the pulmonary artery systolic pressure and is really just there as a measure of pulmonary hypertension. So when you go over the structure of the assessment plan, remember that the summary statement is what you're most likely to get feedback on. This is where, if listeners have tuned out and you say, in summary, everyone's head suddenly turns in and everyone wants to hear how you summarize a patient. So you are going to take the one-liner that you had at the beginning, you're going to condense the past medical history even more because you do not want a multi-sentence one-liner, and you're going to state 1 to 2 things that you found and what the findings are concerning for. So please try to keep this as short as possible. I remember when I was a 4th-year med student, when I was a first-year med student, my 4th-year med student preceptor was going into orthopedics and told me that I had to keep restating the one-liner, but subtract at least 1 to 2 words every time I repeated it until it was as short as possible. If you're the type of person who gives a paragraph-long one-liner statement, that's just not great. And because it's really a matter of, can you synthesize the information? Once you give the one-liner, I want to remind you guys that different than some of the other specialties, we give a one-liner and then any commentary that you have about the problem goes into each individual problem. So I do not want to hear a student necessarily give a one-liner, say their reasoning for all the different things, then say problem number 1, chest pain, we're going to get a stress test. Anything that you wanted to say about the chest pain should all be embedded within problem number 1's discussion and not as one gigantic one-liner statement or impression. So problem number 1, first line is what your differential diagnosis is. So for example here, PE more so than pneumonia, more so than pneumothorax. Then you, in the second line, will say why. And then the third line, what next? So here's the plan for just problem number 1. You will see some people try to present this as, I think this is PE because the person recently took a long bus ride. They have unilateral leg swelling, but their Wells score is 1, so I'm not really sure about PE. I guess it's possible it could be pneumonia because the patient had fevers. So when you do that, it's very hard for the listener to actually sit there and say, what does the student actually think the number 1 and number 2 diagnoses are? So what's much more pleasing to the ear is to have you say this, more so than this, more so than this. Then you can go through the long flowing explanation of why. If you insert the explanation within your first statement, that is, again, even though you said what you think the number 1 diagnosis is, the listener can't remember it at the end of the presentation. All right, problem number 2, same structure, and all the way till the end. You can have chronic problems like problem number 5 is hypothyroidism, continue levothyroxine. Remember that you have the global problem. This is something new that you guys may not have talked about as much when you were pre-clerkship, but this is the final problem for all inpatient notes and presentations. You basically do hashtag global, and then you include what the diet is, what the DVT prophylaxis is, if you need GI prophylaxis, and what their code status is. So, for example, hashtag global, full liquid diet, heparin sub-Q, no GI prophylaxis needed, and full code. In terms of an assessment and plan, as an example, so we'll say problem number 1 is dyspnea on exertion, most likely related to COPD exacerbation from a recent URI, more so than a CHF exacerbation or PE. He did start smoking again with new URI symptoms, had wheezing on exam with no leg edema and a Wells score of 0. He is status post 1 dose of methylprednisolone, 40 of IV furosemide in the ED. I want to continue albuterol nebulizers every 4 hours and continue the prednisone burst for 5 days and hold his home furosemide. So you can see here, I had a crisp differential diagnosis line. Then I explained why. Then I explained what I want to do next. So to round out the brief overview of the oral case presentations 101, remember, do not read word for word. You want to maintain good eye contact. Everyone in front of you has your note on file that they are actually looking at while you are talking. So it's really helpful if you can ad-lib a little more, maintain good eye contact so they have reason to look at you rather than look down at their phone at the note. Watch body language of those around you. If you notice people are starting to get impatient, it may be a marker that your presentation has actually gone on much longer than you think it has. Try to record yourself at home, listen to your voice, and watch your gestures. I used to work on the clinical coaching committee for folks who were deemed to need a little extra practice before going into their sub-I, or interns who might be at risk of not going on to their second year. And so what you really want to do is, people can only give you so much feedback. The best feedback that you get is actually the feedback you give yourself. So I would actually tape record yourself or video record yourself at home giving the presentation. And you will see that what you think might be a 7-minute presentation is actually over 30 minutes. Again, depending on when you're hearing this video, whether you guys have already done a couple clerkships, you will know that you've stood next to a student who thinks they're giving a 7-minute presentation, and it's actually gone on for more than 30 minutes, and they have no idea. Try to present the information with data grouped by differential diagnosis, not head to toe. Group the medications together by organ system, which is much more pleasing to the ear. Focus on having an excellent summary one-liner because that is where you're most likely to get feedback, and have a clear end to the presentation. So for example, last problem, global, full liquid diet, heparin sub-Q, full code. Any thoughts? When you say something like any thoughts or that's all I have, that tells the listener, okay, I have confidence to end this presentation. My voice is not trailing off, and I'm handing it off to you so that you have been patiently waiting to give feedback, and now you can say anything you want to change about my plan. And obviously, remember to keep your audience interested. Energy, tone, and volume. On most of your rotations, you will be listening to 16 to 20 presentations, and you need to basically finish these between 9 and 11:30 a.m. So you can imagine that as most of you are going to be standing up and walking as you're listening to these presentations, people's attention spans are not very long, and so you want to make sure that you keep your energy and tone of voice up. Talk a little bit on the faster side if you can, to keep everyone engaged. All right, so next we're going to go over a sample ED to floor presentation. You guys might actually recognize this presentation as it's one that you saw back in December. But while you're listening, think about if the speaker sounds confident, why does it sound that way? Can you guess the differential diagnosis just from the HPI? What is the speaker's #1 diagnosis? And is it clear or muddled between explanations of other diagnoses? This is a pretty straightforward patient with really only like 1 or 2 problems. So think about how fast you would need to talk based on how your voice is in order to keep this to 7 to 10 minutes. And what information would you exclude from this presentation? And finally, how long do you think this presentation was? So I'm going to say that even I was surprised at how long my first couple drafts of this presentation were because I wanted it to be a good one for you guys. But think about what your natural voice is and how quick you need to speak to keep this within 7 to 10 minutes. All right, so take a listen now. I'm going to let you know it's a little bit of a longer presentation. All right, here we go.
Next we have Ms. Braniff. Chief complaint is stomach pain. So Ms. Braniff is a 38-year-old woman. She's G7P3043 with history of metrorrhagia and constipation, who's coming in 2 days of abdominal pain. So she was in her usual state of health with no abdominal pain at all until 2 days ago. She developed diffuse onset abdominal pain. Her pain is mostly in the right lower quadrant, radiating throughout her abdomen. She says it's about 6 out of 10 in severity. It's constant, sharp and stabbing in quality. Nothing seems to make it better or worse, including positions. She's tried taking Tylenol and Percocet, which she has at home. No benefit there. No trauma right beforehand. Doesn't think there's any relationship between the oral intake and her pain. No change with defecation either. And she's never had this pain before. Around the same time she started having the pain, she also noted some nausea with decreased appetite, but no vomiting. She hasn't had bowel movements since the pain began, but this isn't that unusual for her, considering that she does have chronic issues with constipation and takes Miralax. Her last bowel movement was about 3 days ago. She has also endorsed some fevers and chills, but no night sweats, hasn't actually taken her temperature. She thinks she may have lost a little bit of weight, but isn't sure. In terms of relevant review systems, she denies any dysuria, hematuria, urinary urgency or frequency, no prior history of kidney stones, and no sick contacts. She's not sure exactly when her last menstrual period was, but estimates it was probably about 6 weeks ago, but does have a history of irregular menses. She's sexually active with several male partners, only uses condoms intermittently, no other forms of birth control, has not taken a pregnancy test recently. Of note, she's had no vaginal discharge or pain with sexual intercourse, though hasn't had sexual activity since her symptoms began. She has had gonorrhea several times in the last few years, including one time a year ago, but has never been told she had any sort of complications with that and hasn't been tested for STIs since then. Of note, she is G7P3043, so she's had 7 pregnancies, 3 full-term, 0 preterm, 4 elective abortions, and 3 living children. Her last abortion was 2 years ago and required a DNC. To go through past medical history, she has a history of metrorrhagia, never been formally evaluated, changes pads about 3 to 4 times a day, and her periods last about 5 days when present. Constipation with some occasional hemorrhoidal bleeding, which improves with Miralax. Gonorrhea, as we mentioned, and the pregnancy history, which we mentioned. They were all spontaneous vaginal deliveries. Her children are 5, 8, and 10. Past surgical histories, the 3 surgical abortions last 2 years ago. Allergies, she gets headaches to codeine, medications, Tylenol and Percocet as needed. Social history, she does have an extensive smoking history, 2 packs per day for 24 years. Drinks a 40-ounce beer 2 to 3 times a week, denies any drug use, works as a cleaner, lives with her husband and her children. No PCP, mostly gets her medical care in the ED or urgent care centers. Family history, hard to say, she is adopted. Review systems, pretty much what we already mentioned, noting that she does have some occasional bright red blood on her toilet paper. Physical exam, vital signs notable for a temp of 99.0, heart rate of 108, blood pressure of 110/90, respiration rate of 22, and O2 sat 97% on room air. In general, she's young, mildly uncomfortable, anecteric sclera. She's slightly tachycardic with no murmurs, lungs were clear to auscultation. Her belly was notable for being soft, non-distended, normal active vowel sounds. She did have a lot of tenderness when I push on the right lower quadrant, with some voluntary guarding and mild rebound tenderness, negative Murphy's sign. For rectal exam, she did have some right-sided tenderness, some small external hemorrhoids, no bleeding that we saw. Pelvic exam, normal external GU and vaginal walls. She did have a friable cervix and some moderate cervical motion tenderness on exam. For lymphadenopathy, I didn't feel anything enlarged in the cervical, submandibular, axillary, or inguinal areas, and otherwise normal strength exam. For labs, her CBC was notable for a white count of 15.4 and 92% were SEGs, hemoglobin 14.8 and platelets of 457. Her BMP was notable for a sodium of 132, a K of 3.8, a creatinine of 1.3. We don't have any priors to compare it to. A MAG of 1.6. Her LFTs had an ALT of 14, AST of 13, alk phos of 80, and T-Billy of 0.9. So for assessment and plan, this is a 38-year-old woman, G7P3, with history of constipation and metrorrhagia and prior history of gonorrhea, who's coming in with 2 days of right lower quadrant pain. Also found to have subjective fevers and amenorrhea. Now concerning for possibly PID versus appendicitis. So for problem number 1, right lower quadrant tenderness, I think this is most likely PID, more so than appendicitis, much more so than an ectopic pregnancy or ovarian torsion, and much more so than diverticulitis or pyelonephritis. The differential is pretty broad here. I am leaning toward PID and appendicitis mostly because she also has subjective fevers. At the same time, PID is higher on my list because of the cervical motion tenderness that we found on the pelvic exam. However, at this point, we don't have a UA, we don't have a urine pregnancy test, we don't have imaging. So for plan, I probably want to check a urine beta HCG, a UA, and a urine culture. We can send off cervical gonorrhea and chlamydia samples. We can go ahead and get a pelvic ultrasound to help rule out ovarian torsion, tubo-ovarian abscess, any evidence of PID there. And if that's unrevealing, we may progress to a CT abdomen and pelvis, especially because appendicitis and diverticulitis are on the list too. We can go ahead and screen for other STIs, just given her history, so RPR and HIV antibody, IV fluid, and we can probably give her some Tylenol, 1,000 milligrams every 8 hours. I'm trying to avoid NSAIDs if possible, just given the creatinine of 1.3. My next problem is subjective fevers. So again, I think this is most likely related to PID or appendicitis, more so than diverticulitis or pyelonephritis. The differential is pretty similar to problem number 1. She does have cervical motion tenderness, has had a history of rectal bleeding. So the workup, as we stated, we're getting a UA and a urine culture. I think I'm okay without blood cultures right now, given lack of risk factors, and also holding off on a chest X-ray given lack of respiratory symptoms. Final issue is constipation. I think this is most likely worsened in the setting of Percocet use, in addition to her chronic constipation. So I'd like to increase her daily Miralax to twice a day. That's all I have.
There we go. All right, so now we're going to move on to part 3, which is going to be ICU or outside hospital to floor presentations. So reminder that initially in the review of the 101, we talked about presenting patients in chronologic order or one symptom or diagnosis at a time. And in this case, for ICU to floor or outside hospital to floor, depending on how long they were actually in the other location, you may want to actually consider doing this one symptom or diagnosis at a time. And the reason for that is going to be that some of these folks have gone into renal failure and need dialysis. So you want to talk about everything about their renal failure together. You may want to talk about all the infections that they've been treated for together, and then maybe all the things about their respiratory decompensation together. So as you're giving the initial one-liner, this is going to be a little bit different now because the patient's already been in the hospital for a few days. They've already received a workup. They've had a lot of things that were kind of, hashtag shortness of breath at the beginning that are now hashtag, cavitary pneumonia, for example. So you're still going to give the ED course and the things that led up to the ED course, but you're going to do it a little bit briefer because in this case, you already know that this is pneumonia, for example. When you're looking up information, make sure to include things about when they got blood transfusions, antibiotics, culture data, creatinine trends, procedure dates, because these are going to be things that are going to be kept in a separate part of your admission. So that you remember that all these different things as you're looking through the paperwork from when they were in the ICU or the outside hospital. And always remember to include the initial reason why the patient went to the ICU or the outside hospital, or why they came to our hospital. So for example, you could say that the patient went to the ICU due to respiratory failure requiring intubation, or maybe they got transferred from the outside hospital to Penn because there was a concern for a possible new diagnosis of leukemia, and there wasn't an oncologist at the other hospital. So a reminder that your opening one-liner is now going to sound very similar to what a summary one-liner would, because a hospital course has already occurred. You're no longer in the dark stopping at, presents with cough. Now you actually have a good idea of what that cough was from, and a couple other things have happened. And try to group diagnoses together almost as if you're giving the problem list. So again, talking about all the infections together, then the renal failure together. You're still going to give the review systems, past medical history, and medications, because this is still a new patient to the rest of your team, even though they've been in the hospital. After giving the course, instead of the line, you're going to give the ED course from when they originally came in, but now at the end, where you normally would have in the ED course, you'll say upon arrival to the floor, or upon arrival to Penn, and then say the vitals were this. She continued to report pain, was diaphoretic, and that you guys changed, some part of the plan. As a medical student, remember that you may be the one to look over hundreds of pages of medical records that get printed out and sent with the patient or faxed over to our hospital. And you want to make sure that you're taking notes such that you only need to go through the records one time. What I see some people do is go through the records over and over looking for a different set of information each time, and that's just hard to do. So basically, anything that you want to know from those medical records, as you look at each page, take notes on it so you don't need to go through it a second time. So now we're going to go over an example of an ICU presentation, and whereas you just heard a full admission presentation of an ED patient coming to the floor, now we're just going to listen to the HPI part so you can hear what the one-liner sounds like, how much detail is given about the initial presentation, the ED course, and the hospital course. So as you're listening to this, think about how much do you really need to know about the initial symptoms? Is this patient better presented in sequential order or with each disease course given separately, and how do you feel about the choice of that? Do you know how the patient is doing right now upon arriving to the floor? So for example, does it sound like this note was actually written by the resident before they ever met the patient and then they didn't really meet the patient afterward? And does the opening one-liner remain brief even though you've had a prolonged ICU course? So here we go.
Mr. Williams is an 84-year-old man with mild cognitive impairment, hypertension, diabetes, a known AAA, and multiple prior strokes with residual GJ tube dependence, who presented from home with shortness of breath, vomiting, and was admitted with sepsis, likely secondary to aspiration. He had a large bout of emesis 4 days ago before coming in, likely from constipation per our imaging and the wife's history. He then spiked a fever and was brought in, and a CT showed ground glass opacities in the right middle lobe and right lower lobe concerning for aspiration pneumonia. From the ED, he was admitted to the MICU initially because he had a lactate of 3.6, which did not clear with fluids initially. He was eventually fluid resuscitated and given antibiotics. His fever curve resolved and his tachycardia improved significantly after 3 liters of fluid. For his respiratory distress, he was put on 2 liters of nasal cannula for comfort, but never desatted, and was put back on room air on Sunday before coming to the floor. Regarding his hyperglycemia and diabetes, his Lantus was held on admission due to minimal PO intake and eventually leading to hyperglycemia requiring further adjustments to his insulin. Because he had not stooled in many days and his initial emesis was felt to be from constipation, he had a CT abdomen pelvis done to look for an obstruction and incidentally found an unstable aortic aneurysm plaque. On discussion with the wife, she was aware of the likely impending danger of this plaque and given his age and cognitive impairment, elected to make him DNR as he was not felt to be a surgical candidate. He was transferred to the floor on June 2nd, given his lactate had improved and he was normotensive and deemed not to need a major vascular procedure. His vitals on transfer were a Tmax of 99.1, heart rate of 90, blood pressure of 120/80, and satting 99% on 2 liters nasal cannula. This morning, he did end up having a bowel movement, reported improvement of his nausea, and was able to stand and walk to the bathroom.
All right, and now we're going to go over an example of an outside hospital presentation. Again, we're just going to listen to the HPI here. So think about these questions as you're taking a listen.
Ms. Turner is a 69-year-old woman with a past medical history of COPD on chronic prednisone, hypertension, mitral regurgitation, and tobacco use, who presented from an outside hospital for shortness of breath, now with concerns for possible T-cell lymphoma, transferred to HUP on June 1st for ongoing workup and evaluation. In September 2019, the patient had a CT chest that was abnormal with a right lower lobe pulmonary nodule that was spiculated and concerning for malignancy. She therefore had a PET scan in October showing avid FDG uptake, and then had a CT-guided biopsy of the lung that demonstrated abnormal cells without clear diagnosis. She had a repeat CT scan in February that showed almost complete resolution of the right lower lobe nodule, but with a few new scattered pulmonary nodules. At that point, she was referred to oncology, who she saw on March 3rd. There was concern for inflammation versus early T-cell lymphoma, so she was referred to another oncologist. Repeat imaging was more suggestive of lymphoma. There was a plan for her to seek outpatient evaluation for second opinion with Penn Oncology, however, this had not yet been done. The patient presented to the outside hospital on May 24th with altered mental status and hypoxia. For her hypoxia, she initially required BiPAP and admission to the ICU. She was started on antibiotics with ceftriaxone and azithromycin for possible community-acquired pneumonia, and eventually was weaned to 2 liters nasal cannula. In regard to elevated Tylenol levels, she was found to have an elevated Tylenol level and a transaminitis upon admission to the outside hospital. She denied any suicidal ideation or attempt. She noted she had been taking Tylenol for recent knee pain and did not mean to intentionally overdose. She was treated for the Tylenol overdose with N-acetylcysteine and seen by psychiatry, who agreed this was likely not a suicide attempt. Her transaminitis eventually improved. In regard to her right lower lobe nodules, upon having a CT scan for the hypoxia, she was found to have enlargement of the right lower lobe nodules with more scattered nodules, and thus a transfer was requested to HUP for further oncologic workup. This morning, upon meeting the patient and family were frustrated by the visitation at HUP and initially requesting transfer back to the outside hospital. Upon further discussion, the patient is agreeable to stay at HUP for further workup of her hypoxia and lung nodules. The patient states she is very frustrated over the past few months of being told she has cancer and then being told she does not have cancer. She has a very labile mood. She denies active suicidal ideation. She does endorse some passive SI, saying, well, if the next biopsy is not diagnostic, then I should just give up. She's willing to stay for further workups, currently denies chest pain or shortness of breath, and this morning was weaned to room air.
All right, now we're going to go over subsequent day presentations, also known as day 2 presentations or SOAP notes. What this means is maybe on Monday you admitted the patient, on Tuesday morning during rounds you gave your presentation the entire, HPI and H&P for admission, and then now this is Wednesday. The team already knows about your admission presentation from yesterday, and they're really considered like a subsequent day presentations where you're just going over the elements of a SOAP note. So the goal here is going to be 2 to 5 minutes depending on complexity. And remember that there's a lot of information that you don't need to repeat. You don't need to repeat all the radiology and the labs that were present yesterday. You can just talk about things that are new now. So remember, SOAP stands for subjective, objective, assessment, and plan. The subjective part is now going to be your updated one-liner, which now includes things like now awaiting or currently being treated for, with the medical history, and presenting with part much shorter. Now you're going to go over the 24-hour interval events. So what happened during the day yesterday, what happened overnight, and how are they doing this morning? For objective, you're going to go over vital sign trends, physical exam, mainly just focusing on things that are different than yesterday, and any new labs or radiology. And for assessment plan, remember that you want to rename your problems and reprioritize them depending on what information has transpired since then. So what was chest pain now that you have the troponin and the EKG changes, you could say, yesterday's chest pain is now problem number 1 in STEMI. And you don't need to necessarily explain the whole differential again because you have this information now. You can just call the problem in STEMI. So here's an example. If I were to say the original admission opening one-liner was, Mr. Reynolds is a 75-year-old male with a history of hypertension, diabetes, prior inguinal hernia repair in 2007, and prior mesenteric ischemia, now coming in for acute onset abdominal pain after eating. On day 2, with things having already occurred, now my one-liner is going to be a little bit shortened in terms of the past medical history. I'm going to say what they've been found to have and what we're currently awaiting. So, for example, Mr. Reynolds is a 75-year-old male with a history of prior inguinal hernia repair and mesenteric ischemia, admitted for acute onset abdominal pain, now found to have a lactic acidosis and CT findings with mesenteric ischemia, currently awaiting vascular surgery consult with plans for possible angiogram. In terms of 24-hour events, you could say, in the last 24 hours, we contacted the patient's son, who's planning on coming in today. His lactate trend went up from 3 to 5 despite 2 liters of normal saline. Repeat CBC showed a hemoglobin drop from 9 to 6.9, so he got a unit of packed red blood cells overnight. And overnight, the night float was called to his bedside for new chest pain. EKG showed no ST changes, and after simethicone, his pain went away. For morning events, this morning he reported his abdominal pain was still an 8 out of 10, worse than the left lower quadrant. He still is hungry in the setting of being NPO and asked us to call his son again. For vitals, and remember, you want to kind of give an intentional pause between subjective and objective sections, especially if you're talking a little bit on the faster side. So for vital signs, Tmax was 100.4 at 3 a.m., currently 99.7. Heart rate was in the 110s overnight, currently in the 100s. Blood pressure range 120s to 130s over 70s to 80s. Respiratory rate 16 and setting 93% on 2 liters nasal cannula. On exam this morning, no acute distress. Lungs were clear to auscultation. Cardiac exam notable for tachycardia to the 100s and a more noticeable 3 out of 6 systolic murmur in the left upper sternal border with abdomen showing less scarring, no rebound tenderness, and leg edema went from trace to 1+ this morning. So for summary one-liner, Mr. Reynolds is a 75-year-old male here now with acute on chronic mesenteric ischemia, currently awaiting vascular surgery consult with plans for possible angiogram. So notice how a lot of the medical history and a lot of the presenting things have been taken out here, and now we're just saying what they're here for. So problem list, remember to rename and reprioritize. So problem number 1, previously acute abdominal pain, now felt to be acute on chronic mesenteric ischemia and now worsening. So we called vascular surgery to discuss angiogram and possible stenting this morning. We'll keep him in PO except for meds now. We'll continue maintenance IV fluids with D5 half normal saline at 125 cc's an hour. We'll continue trending lactate levels, next one at 10 a.m. And then you can go through and discuss the other problems. All right, so let's go over a summary of the tips that we've talked about so far. So remember, try not to read word for word from paper or your phone if you're looking at Epic on the phone. Try to maintain good eye contact. The more you look at someone else, the more likely they are to look at you rather their own phone or their email, for example. Watch the body language of those around you. If you notice that everyone has decided to go call consults, it may be a marker that either your voice isn't enthusiastic enough or you've actually gone on way longer than you think. Record yourself at home, listen to your voice, watch your gestures. So remember, the best feedback you can give is the feedback you give yourself. So tape record yourself, video record yourself giving a presentation. Take a look at the time, take a look at the volume, the intonation, your gestures, your eye contact, and figure that all out for yourself so that you can tell yourself that feedback rather than someone who's grading you telling that feedback. Present information with data grouped by differential diagnoses. Try to group medications by organ system. Have an excellent one-liner that is brief and to the point. Have a clear end to the presentation. So remember, that's where we said, that's all I have, or thoughts. At the end of the presentation, that's going to be a huge marker of confidence points. When you have someone who trails off at the end and says, you know, they're on heparin sub-Q, prophylaxis, and GI soft diet, and right, that's the person who loses confidence points in their oral presentation. And remember to keep your audience interested with energy, tone of voice, and volume. Try to keep new patient presentations no more than 7 to 10 minutes. This is going to be extremely hard. Your first presentations could easily be 30 to 45 minutes. And you probably think I'm crazy for saying that. But my first presentation, 45 minutes, everyone was so nice to me that they didn't stop me. And we ran until 1 o'clock that day. So remember that no one's going to really stop you because they're trying to be nice to you. So it's up to you to realize that you've gone over the 7 to 10 minute mark. I will say that I'm normally a pretty slow talker before I became an intern and a doctor. And I had to realize very quickly that the residents and even the sub-Is are getting so many phone calls from nurses and consultants that they have to talk fast enough to answer the next call that's on call waiting. And so you have to keep rounds moving. And I, over time, had to train my voice to hear what do I sound like when I talk 7 to 10 minutes for a patient presentation. It's not my natural voice. If you go out to have lunch with me, I don't talk like that. But on rounds, that's how I have to talk in order to get all the information done, see the patients, have a discussion with the team, and go see the other 15 to 16 patients. Remember to use a more problem-based rather than purely chronologic-based way of putting together the HPI for most ICU or outside hospital transfer patients, not all. For SOAP notes, try to strive for 2 to 5 minutes depending on complexity, and make it clear that you put your money on a diagnosis and that you've renamed and reprioritized your problem list. And one more time, remember to keep your audience interested by your energy, tone of voice, and volume. I can't say enough how important that is because you are listening to 16 to 20 presentations in a 2.5-hour time span. All right, well, thank you so much. Definitely feel free to reach out with any questions. I hope to see you guys on the wards. I often will attend on the Martin service for about half the year or so. And best of luck as you go through a clerkship year. Thanks so much.